Thank you everyone for coming to our talk today about simulation and respiratory motion management. And thank you, Dr. Dieterich, for giving the talk today. So feel free to ask any questions in the chat, or you can also raise your hand through the feature here during the talk as well.
Mhm. Thank you. Good morning, and thank you for everyone attending this lecture. So today we're going to talk about simulation and respiratory motion management. And when I put this lecture together, it was a little bit of a challenge for me because what you can do is so dependent on what type of equipment you have, and there's a wide variety out there now. But I've tried to cover a little bit of everything, and as usual, 45 minutes is an introduction to it and an invitation to dive deeper into the topic. So in this lecture, we'll start by talking about, okay, how do you commission your new simulator? Some of you may have gone from a conventional X-ray simulator to CT. Some of you may have had your CT for a while. Then I'll say a few things about simulation itself. It's not that different from 3D simulation. There's just a few pointers what to think about. I think the majority of my talk, I'll speak about motion management strategies for respiratory motion, because that's where IMRT is really the most different from 3D planning. I'll cover at the end a little bit about artifact prevention in your imaging, and we can discuss some common pitfalls and how to prevent them. So a CT simulator is essentially a regular diagnostic CT scanner with some additional features. We put in external lasers to reference the isocenter to our isocenter in the Linac room. And instead of this nice round couch that you find in radiology, we have the flat couch that mirrors our couch on the treatment machines and has sometimes little indexing devices. There's some important practical tools that you have to think about when you install your new CT scanner. And in my place, we've just replaced ours, and we talked about this extensively when we looked at machines. So first of all, in radiation oncology, we don't want a gantry tilt. So in radiology, sometimes you can often you can rotate your gantry, which is done, for example, for brain imaging to get standard slices. We do not want that here in radiation oncology. So what I was looking for when we looked at scanners was scanners that would allow you to lock the gantry tilt in a way that it cannot be easily overwritten or accidentally changed. And that is for safety reasons, because if you image at a tilt, you will not get a correct treatment plan. We are also looking for a large bore size, not only because we have some large people, but also we have set up devices like breastboards, belly boards, and other things that need to fit through the scanner. So when you look for scanners and you have two scanners that have similar properties, take the one with the larger bore size. It will help a lot in practical clinical workflows. You also want to have a large field of view for the image itself. And again, this is predominantly for the larger patients that we have, because, in IMRT, especially when you do rapid arc treatments, your beams are entering the body from all different sides. And if you can't image the surface properly, because your field of view is too small, you're going to have very limited ability to get a good IMRT plan. Also, when constructing your room, remind people to think about storage for simulation devices that your therapists are going to be using. This often gets underestimated how much you actually use and need. And also, you need some storage in there for physics imaging phantoms that you should also think about, to have a closet reserved for physics. So AAPM has a task group that has good information on CT simulator commissioning. And there's actually an update of this task group in progress that should come out in a year or two to update some recommendations. Well, the first thing you're going to do is, when you commission your CT scanner, you're going to do a shielding survey. as we do with our Linux, to verify that our exposure levels are within the regulations in your country. And then also when your CT scanner is commissioned, we also do the first patient dose measurement, the CTDI, to verify the dose delivered from a scanner. So typically these phantoms look like these big cylinders with spaces for a 10 cm ion chamber. In some places where I've worked, radiation oncology did not have these devices. We use them once a week, once a year. And our colleagues in diagnostic radiology were willing to help us out and came over once a year and did these measurements with us. And what we did is we picked one typical protocol we use for head scans and one for body scans, and used that as our QA scans for the CTDI measurements over the years. There are many, many tables in there in TG266, and I won't go in everything. On the right-hand side here, let me get my pointer out, laser pointer. On the right-hand side here, you can see the table that lists test specifications for image performance, and these are typically done with an imaging phantom. The vendor often provides these, or you can buy your own, loan one from radiology. We're looking for CT number accuracy for our treatment planning accuracy. We want to have low image noise so we can actually distinguish features in the patient. Spatial integrity is very important for radiation oncology. Field uniformity as well. Electron density to CT number conversion is the basics of our planning system. And we also measure spatial and contrast resolution. In addition, we're doing a lot of tests that are in addition to what radiology often does, and that is our electromechanical tests. So for example, we need to know if our gantry lasers that we have in the room are aligned with the center of the imaging plane. And the spacing of the wall lasers needs to be checked with respect to the lateral gantry lasers and scan plane. And I purposely cut off this table here because I think it goes over roughly 2 pages. And we will provide this task group to you, will be shared with you, is always free on the AAPM website. But it's a very detailed table that explains what mechanical items you need to check, why you need to check it, how often you do it, and what the tolerance limit is for this. So I'm sorry, this is a double slide that's in here. So once you have your CT scanner commissioned and you've run through all of these tests for your first time, you're ready to simulate the patients. So what is the purpose of doing this? First of all, we want the patient in a reproducible position, and that is very similar to our 3D patients. So because you need to reproduce the position 30 times sometimes, and it needs to be the same on simulation day than for treatment day, it is important to make really sure that the patient is straight, the spinal cord is aligned sagittally, the spinal column, the patient is not rotated on the couch or in a funny position that would be hard to get into. One trick we actually use is sometimes we put the patient down, and if we're not sure it's reproducible, we make the patient get up and go down 1 or 2 times, and that usually works out all these little kinks and gets them in a good position. What I have learned also is that it is important that the patient is in a comfortable position. The reason for that is that IMRT treatments, especially once you move to stereotactic body radiation therapy, can take longer. And if the patient is uncomfortable, they will start to move, and that defeats the whole purpose of simulation. And one example I always give is head and neck patients. I said before, it's always important to have the spine aligned to the sagittal laser, very straight. But sometimes head and neck patients, especially if they had surgery before, they're a little bit crooked. They have a crooked neck, or the shoulder is a little bit up. And if you try to straighten them out, it hurts them and makes them uncomfortable, and it requires effort. So for those patients, it may actually be better if the head is a little bit crooked or the shoulder is a little bit up, if that is their relaxed position they're naturally going into because of anatomical changes in the head and neck anatomy. Also check at the bottom on the, if you use vacuum bags, there are no bumps in there, that there are no bumps that could create pressure point, or if you have a mask, sometimes in the back of the head, you don't want to have pressure points either. Lastly, we need to have the patient in a good planning position. So if you're treating in the torso and you know you're going to do a 360-degree VMAT, you want to have the arms up so that you don't go with the beams through the arms. Also, sometimes when you have a very lateral tumor, say in the shoulder, you want to shift the patient in the couch a little bit, because when you set up, because you don't want to have to shift the patient over a lot for planning, which could then cause collision issues. So think a little bit about how much lateral motion you have before you get too close to the gantry for your arcs or your field deliveries. There are a lot of immobilization devices out there. And the classic, of course, is the thermoplastic mask for cranial treatments. Sometimes they, for head and neck, they extend down to the shoulders. The vacuum bags have become the standard for body treatments. They come in all kinds of different configurations. Some even have little indexer bars. For treatments in the gastrointestinal region or for anal rectal cancers, we use a lot of prone boards that can, immobilize the patient well and let the bowel drop away by gravity from the area we're treating. And these prone boards can be a little bit expensive, but frankly, at my previous employer, I just took our shop mechanic and we built one ourselves. Is not that hard, honestly. So if you can't, if money is tight, think about what you can do with some good pieces of hard foam and some tools. And it's a lot of fun actually to build these. I always recommend that these devices have indexers that you can clip onto the couch, because that gets your patient on the correct position longitudinal on the couch every single time. So when you have your patient and you're on your simulator, you're going to mark your isocenter after the volume data is taken. You get some good 3D anatomy for planning. And you even can have digitally reconstructed radiographs if you do KV matching for imaging setup. A word on imaging protocols. We're shooting for a little bit different purpose than radiology. Radiology is all about good contrast, but they also care about dose. So they're looking about pushing the dose down. However, we in radiation oncology, we are comfortable giving a little bit more dose for the sake of getting really good image quality. This here is obviously an older protocol if you look at the slice width here, but I put this in here to give an example of what you should build in your institution over time. And often your CT software allows you to put these protocols in. So over time here in my center, we've created CT protocols for every IMRT site. So for example, here you have a lung, and then our patient SIM card says, okay, we're doing supine, we're extending the chin, the arms are above the head. We can take the 5 or 7 cm sponge, that's a padding. We're immobilizing with an alpha cradle. The initial reference setup point should be at the carina and midplane, or per MD instructions if it's different. We have a list of CT protocols we can use for that, depending on slice thickness. Nowadays, we would do 3 millimeters or less. We tell the therapists what the scan limits are. So for lung, we always scan chin to the apex of the lung, through the target, through the rest, to the top of the kidneys. Or if the MD wants something different, we'll tell them as well. Contrast is very important. You need to be consistent from scan to scan, so that when you're contouring, you know what to expect. And then there is special instruction usually. It takes a little bit to create protocols. We just created a new one yesterday at my site for a breast brachytherapy. But again, generally for IMRT, you'd want to have slice thickness of 3 millimeters or less, which most scanners nowadays can accomplish. And just, make the description as clear as possible. CT simulator scanners often have softwares that can provide beam's eye view that can create ray tracing through the anatomy. This is very helpful if you want to set up your IMRT beams at the scanner already to give your dosimetrist some starting point from which to work. The magnification is usually programmed in based on your Linac scanner geometry, panel geometry, and the grayscale is set by the Hounsfield unit of the CT scan. I wanted to say something on tattoos. When I started in medical physics, we used tattoos on every patient to mark the isocenter, and that used to be standard. And over the recent decade or so, we have gone away from that. And there were several reasons. First of all, if you have tattoos, every time the patient looks at their body, even if it's 10 years or 15 years after their radiation treatment, they have a visual reminder of their disease. And that is really creating a low-level stress on our patients. It's always so, oh, I have a tattoo, I had cancer treatment. We also found that we had patients coming back for retreatment because cancer survival rates are better. And if you have old tattoos versus new tattoos, that can actually cause errors because the therapist could, select the incorrect tattoos for setup. Also, if I just look at our attendees here, we have a wonderful variety of skin colors here. And, my cousin married a wonderful gentleman from Ghana, and tattoo on his skin is clearly not visible versus a tattoo on my skin sticks out. So we thought that tattoos, in the United States, we also have a very diverse population from all over the world, and tattoos weren't really a good tool. And especially once we got IMRT and we got all this image guidance, we ask ourselves, are these tattoos still needed? And, it's helpful to have an external marker because it helps you to see if your setup device is indexed correctly on the table. It's a good visual check for initial setup. And especially when you do thoracic or lumbar spine treatments, adjacent vertebral bodies can look very similar. And if you have a tattoo or some mark externally, you can easily check if you are registered on the correct vertebral body. So what has developed as the current state of the art marking on the skin in a lot of centers that I'm familiar with now is we're using permanent markers. We have Sharpies everywhere. And when you mark somebody with a Sharpie and cover it with, we have these transparent wound dressings. In the United States, they go under the brand name of Tegaderm, and they're waterproof. So you can put a Sharpie marker on the skin, and you put some of this transparent dressing over it, and the patient can actually wash around it, not shower, but it actually keeps the marking present for quite a long time. And if they fade a little bit, you can always reapply the marker and put that dressing over. If you, like me, had a kid who paints themselves with a Sharpie, you know how hard this actually is to get off your skin. And they come in a lot of different colors. I have used silver ones for darker skin colors. They show up really well, and you can kind of play around with skin tone versus Sharpie marker on what shows up really well. Appropriate margins, I wanted to say a word on that before we jump into respiratory motion. The quality of your simulation has a big impact because it affects your setup margin. If you have your gross tumor volume here and then some subclinical involvement that you're covering, you will then create some internal margins that I'll talk about a little bit later based on your residual motion of the tumor on respiration. But there's also a setup margin that ensures that we have adequate clinical coverage, and that includes all uncertainties of your simulation and treatment setup. These are the random uncertainties. You know, we all lie down each day a little bit differently, so our bodies changes. But there's also systematic uncertainties. For example, if you have a setup and you can't get the shoulder in a reproducible position and you're always off the same way, you have a systematic uncertainty. And a good simulation will make sure that you can define your setup margins well. They're small enough that they're appropriate for IMRT and eventually SBRT treatments. I wanted to talk about site choices. We're doing IMRT itself over the whole body. But when we're looking at things that we need to pay special attention to with reproducibility and motion management, we have to look at sites where motion tends to be larger than 1 centimeters, or nowadays even 5 millimeters. And typical targets where this is the case is where we treat very often is the liver, lungs. Unfortunately, a lot of people in the United States still smoke. It's an issue. And pancreatic cancer. We typically don't treat kidney cancers because they're very radiation hardy and they don't respond to radiation very well. So these are the 3 classic sites where you have respiratory motion that you need to consider. There are also some patient-specific considerations. If we're treating in the upper lung, you often have very, very small motion, way less than 1 centimeter. And some patients I've seen have naturally shallow breathing. Actually, they go on the table, you don't have any motion management, and their respiratory motion is well under 0.5 centimeter. That is actually fairly rare, but nice to have. So in about 15 years ago, we started to understand a little bit better how lung tumors move with respiration. And as you can expect, if you have a bronchial tree here, anything that's inferior in the body, close to diaphragm, has very large excursions. If you look at anterior, you can get a little bit of a loop-like motion. And the closer you come to the upper lung and to the center of the lung, the smaller your motion tends to get. Liver motion is a little bit different because the liver sits on the gastrointestinal section, which doesn't move that much with respiration, but it also abuts the diaphragm, which has the largest respiratory motion in our body. So you actually find this big gradient of motion over the liver with very, very little motion at the inferior parts of the liver and very large motion up here near the diaphragm. So if you have tumors in different sections of the liver, you will find different motion excursions that sometimes even differ across the tumor, and that causes some deformation. So how do you deal with that, especially when you're doing IMRT? And the answer is complex. It depends a lot of what delivery technology you have and how old that is. For example, in my clinic, I have an older Elekta Linac that cannot perform gating, and I have a newer Elekta Linac that can do gating and breath hold and all kinds of good things. So you have to look at your Linac and see what you can make work with your machine, and then use that same technique for your CT simulation to manage motion. And what you then choose on your internal tumor volume motion margin really depends on the components of uncertainty specific to your motion management technique. So how much residual breathing motion do you expect? Is it 1 centimeter? Is it 5 millimeters? Is it 2 millimeters? Are you in an area like more the center of the lung where you have rotation of the tumor, or are you somewhere in the liver where you have deformation? There is actually a very nice task group that gives you an introduction in all the good details of this from the AAPM. It's task group 76, and there's also an update to that in progress. So I highly recommend reading that for more detailed information. So our goals in managing the respiratory motion of the lung, pancreas, and liver is to reduce our ITV margin volume. So what you need is a treatment delivery device that has technical capability to do motion management. You do need a CT scanner that is capable of 4D image acquisition. Actually, most of the CT scanners that were produced in the last 10 years have that available. You need 2 instances for respiratory motion technology, because you need one in your CT simulator and a matching one on your Linac. You also need a planning system capable of handling 4D CT. Again, most planning systems in the last 10 years have added that. And you also need time in your schedule for longer treatment appointments. Your whole team needs to understand what you're trying to do here, and you also need to develop and test the workflow and give them good instructions. So I always recommend have an easily accessible procedure manual where you can stick the instructions in. We have that online, and we're reviewing this periodically to make sure everything is up to date. So over the years, 4 technical approaches have developed for motion management. The oldest one and the most straightforward is abdominal compression. The second one that got implemented is gating. Then we have deep inspiration breath hold and tracking, which I will only mention because it's still in development for external beam Linux. So compression, we still use this at my center. It is very straightforward and very easy. You need some kind of setup device that has a method to compress on the diaphragm. These could be with a paddle like this. Sometimes they have tight belts or bellows. And what this device basically does is to remind the patient to breathe very shallowly during the treatment. So after you've got the compression device set up, you can visualize the tumor on fluoroscopy and check that you have compressed the patient enough that the motion is below 1 centimeters. And once you're there, you can perform your 4D CT under compression to account for your residual motion. A word of warning, I found that when you start to compress a patient, their breathing gets more shallow because they can't breathe against that device. You can easily imagine that. But if you press too hard, they start working against the device. They're getting too stressed, and then the motion amplitude actually goes up. So you're defeating the purpose. So sometimes when you're compressing and it gets worse and worse, if you ease up, it actually gets better. There's also some patient limitations. Not every patient can tolerate that. Some frailer older patients, or if they have an aneurysm or some medical condition that prevents compression. For all the other methods, the gating, the breath hold, and the tracking, you need some way to monitor the motion of the patient during treatment. So you need to figure out how to do that. So there's different devices that have come up, and I've shown a few samples here. There are some breath hold devices, some visual monitoring with a block. This is the Varian RPM, and we also have surface imaging devices now. So there are lots of papers out there that show the different devices and how they work. I want to point you to a particular paper that is actually open access in the journal Practical Radiation Oncology. And this is a site in Spain that built their own respiratory motion device. They have very good instructions in that paper. You can pull that out, and actually for not a whole lot of money, you can build your own device that they have shown works really well. And I happen to be one of the reviewers of this paper, and I thought, yeah, I can build that with a couple things I can pull out of the garage and get that working. So not necessarily need to buy a very expensive external beam motion monitoring device. There are actually ways where you can build a high quality device at home. So what do you do with that? In our static 3Ds, CT simulations, we usually have free breathing, or we have inhale or exhale breath hold, but that doesn't give us any information on the motion. So if you have a way to monitor the motion, you can actually do the following. If this picture shows you what happens during the CT exam, and these are 3 couch positions, you're taking repeat images at each position, and ideally you'll get a couple different phases at each couch position. I put down just 4 here: full inhale, mid exhale, and full exhale. And you get all these images that are mixed together in different orders depending how the patient breathes when you image at that certain couch position. And after the exam, after your simulation, your software actually sorts all of these, so reshuffles all these images. So you get, for example, here a full exhale CT set at each couch position and a full inhale CT set. And you typically nowadays we use 10 phases for breathing to model our respiratory motion, and we get that automatically from our CT simulator software. So we can use this, for example, to set up amplitude-based gating, which is one of the most common motion management techniques. And the reason is that it's simple. Your patient can breathe, it's free breathing, and you just tell your Linac that you only want to have the beam on during this gating window. We typically set it around 30%, which is shown here, so 30% of maximum amplitude, but you can also go down up to 50%. Depends a bit on how much the tumor moves. And so the beam is on during these times. You can also do phase-based gating, where you say, okay, if I have the inhale phase and the exhale phase, I want to just gate on these phases. And the same idea, you'll have the beam on during here. Which one's better? There's one paper out there, not too many patients, but it shows that if your duty cycle is below 30% and you have amplitude-based gating here and phase-based gating here, for low duty cycles, amplitude-based gating is generally the better one. Here's a paper that actually published in Impact. So how much better can you get when you treat a liver tumor when you gate it? And you can see you get slightly better coverage, which is better for tumor control, but you also get significantly better dose sparing, especially the left kidney here and the right kidney, and also the cord, you give lower dose. So well worth the effort. If gating, on the other hand, and I'll go back to this slide here, you can see that your beam on time is, of course, with a gating window of 30%, increases your treatment time by a factor of 3. And so deep inspiration breath hold has been developed to take care of that because it's a bit faster than gating. In its simplest form, which basically everybody can implement, is you can give the patient verbal cues as a therapist, breathe in, breathe out, breathe in, hold your breath. And then you let the patient hold their breath, typically for 10 to 20 seconds, depending on the patient. And during that time, you treat, you beam on. And then when the patient needs to breathe again, you switch the beam off. It can be a very, very low-tech implementation, actually, if you closely watch the patient. If you have a surface monitoring device, the same as we use for the gating techniques, you can actually use that to give the feedback to the Linac on when to switch on and off the beam. Most complex, you actually have something like the Elekta ABC or other devices where the patient actually can see their respiratory motion. And once they hold their breath, they actually have a button here that closes a bellow, helps them hold their breath and switches their beam on, and the patient can release that and switch their beam off. That's the most sophisticated version. So usually when breath hold was first instituted, we had big debates. Is it better to hold the breath on the inhale or on the exhale? The exhale has the advantage that it's a relaxed position and you have very little uncertainty in the reproducibility of the position because all your muscles are relaxed. Inhale tends to be a little bit more, has a little bit larger uncertainty because when we inhale, we tend to tension our muscles at different positions, and you can play around with that at home. However, most patients honestly have an easier time holding their breath on inhale. It's just physiologically much better for our brains. If somebody tells you hold your breath, you inhale and hold your breath. So we always use the deep inspiration breath hold nowadays. So again, breath hold, most patients can do 10 to 20 seconds. I challenge you at home to try and hold your breath in 20 seconds intervals for an IMRT treatment. Even for a healthy person at 20 seconds, it gets challenging at the end of treatment. And of course, this technique is very dependent on your patient's lung function and compliance. If your patient doesn't hold your breath when you tell them to, or if they're just too short of breath, it will not work very well. The position reproducibility to go to the same point in inspiration breath hold tends to be 1 to 2 millimeters, and then you have to add to that a slow drift over the breath hold interval of also about 1 to 2 millimeters. But again, like gating, there is a lot of impact. Lung treatments, you can have a 20% reduction on the V925. You can get a 7% reduction on the cardiac hotspot and the cardiac 440. Again, breath hold and gating take longer because your beam is not continuously on. So you need to make space for those patients in your treatment schedule. I'll have just 2 quick slides on tracking because I wanted to give you an insight what may be coming your way. So tracking has been available on the CyberKnife machine for 17 years now, but that would be a completely separate lecture. I won't mention that. For those of you who have Linux with MLCs, there are actually clinical trials on variant MLCs right now, possibly on Elekta soon, where they move the MLCs with the tumor motion. And I have a little screenshot from AAPM TG264, which should be published in 4 to 6 weeks. It's been accepted. So if you have, for example, a lung tumor motion that goes up and down and it's parallel to your MLC position, you can actually move your MLCs with the lung tumor. You can also do that in perpendicular position. It's a little bit more challenging. If you have magnification along your beam, you can also do that. And if you have rotation, that's really complicated to do. You could also eventually adjust for that. It is actually a pretty cool technology. I gave you a link here to one of Paul Keel's YouTube channels, videos where he shows how that works. And I encourage you to go there and take a look. It's actually pretty cool. It doesn't require a technical change to your Linac because once you have a motion monitoring device and an MLC which can do that, the vendors just need to release the software license for that and can make that work once it's approved by the regulatory agencies in your various countries. So it's actually pretty exciting technology because it would allow the patient to breathe normally without any special setup devices that cost money and take time, but you could treat continuously throughout the motion cycle without losing time on your Linac. And I know a lot of you are really, really busy on your Linux, and if your treatment gets shorter, it's actually very helpful. So once you have all these margins and your motion management from your simulation, you can use the breathing phase data to construct your ITV. So you could, for example, contour on each of the 10 phases and then create an ITV that encompasses all of your residual motion and then add your setup margins. We construct 2 scans from your 4D CT simulation image. One is the maximum intensity projection to check that your ITV is indeed correct. And the other one is the average intensity projection, which is recommended to use for planning. If you can't create an average intensity projection on your software, alternatively, you can use a free breathing scan where you really slow down your CT scanner, and it's kind of it's a way to create an image study that is fairly similar to an average intensity projection. I put in some recommendations from the literature for some general margins depending on what you're using, and you can see they tend to be 5 to 10 millimeters. So 5 millimeters radial, 10 millimeters craniocaudal. And when you start out with respiratory motion management, I always recommend start with these numbers. They tend to get you in a very safe place, as proven by all of these clinical trials. So in summary, respiratory motion management is very helpful to reduce the ITV margin for lung, liver, and pancreas. It has significant dosimetric benefits, lower toxicity. And what method you choose to use really depends on your resources and your technologies. A lot of times you actually can get by with fairly low-tech approaches, which tend to be also very robust. The method may also be dependent on your patient tolerance. So I mentioned compression should not be used if you have an aortic aneurysm in your patient. Breath hold may not be appropriate for a patient with chronic obstructive pulmonary disease. You need to adjust for room time because you also have setup of devices. You need to QA that your motion is the same as at simulation, and you have a duty cycle issue with the gating and breath hold that increases your beam on time. In artifacts in 4D CT acquisition, these are the most common four. So you can get blurring here. You can get duplicates of the dome of the diaphragm is most easily seen. You can get these overlapping structures artifacts, or you can get incomplete artifacts. And usually if you look at the dome of the diaphragm, that's where you see these the most clearly. So what causes these artifacts? And my colleague Tokihiro Yamamoto actually looked into that, and he said, most common reason is respiratory irregularity, because it's then difficult for your sorting algorithm on your CT that I showed earlier in the lecture to pick out which breathing phase the patient is actually in and shuffle the images around the correct way. Also, if you have a very big motion amplitude per breath, that speeds up the motion relative to your image acquisition, and that can also cause these issues. The solutions for these things is that to increase your scan speed. And I have to say, 15 years ago, our CT scanners were a lot slower. Any CT scanners that were built in the last 10 years or so, they have very fast scan speed, they have multi-slice acquisition, they have very accurate helical scan protocols. So this has actually all had an impact that these amplitude issues have not been as common as they used to be just 10 years ago. So what I'm saying here is that when you construct your imaging protocols for these scans, think about the scan speed and try to keep them as fast as you can to minimize the amplitude issues. Under respiratory irregularity, there's actually another solution, and that is audiovisual feedback. And I'll show you some older slides. Essentially, you're monitoring the motion, as we've talked about before, many different ways. And then you give the patient the feedback on what this motion is. In this specific case, we bought some gaming video goggles. They're coming down in price, so they're not as ridiculously expensive as they used to be. Or nowadays, we mount our iPhones on a stand in the room and or any other little tablet or whatever you have available, and you can feed that motion signal back into the room so your patient can see that. Again, it's another do-it-yourself project that is high quality and high impact and fairly easy to do. So you're tracking that, and that can actually get your patient from a wildly varying free breathing motion pattern into something that is much, much tighter across their kind of average breathing amplitude. And this was a healthy young person. You can see how much our breath naturally varies. But we humans, we tend to be good, and especially since video games come out and my grandma plays video games, patients are actually pretty good at gaming their breath and following that, and that can take care of a lot of the motion artifacts that you have. So with that, we're already at the end. Lots of information on simulation. But just to summarize the major points, your simulation CT scanner has slightly different goals than diagnostic CT. And that makes the QA also slightly different than diagnostics, because couch motion and lasers play a much larger role in getting a good simulation done. But there's also significant overlap with radiology with regards to image quality, which means you can work with your colleagues over in radiology to maybe share some resources. And I do this regularly. A good quality simulation position, the reproducibility, the patient comfort, and the avoidance of collision can make a big difference for planning, margin size, and treatment. If you have respiratory motion, if you can manage that, because it helps you reduce your margin, especially once you get comfortable with implementing IMRT at your centers and you're going to move to more hypofractionated regimes or even to SBRT. As with all new processes, go from simple to complex. Start IMRT in maybe pelvis. Cervix is a great case. Cervix doesn't move very much. It's fairly easy to plan. Oops, I have a typo there. You can take your time, talk and think through, and then you go to more complicated targets. You go to the head and necks, which are more complicated to plan, and it's a little bit more difficult to simulate, and then you approach anything that involves motion management. And with that, I want to thank you for your time. And again, all of us lecturers, and if you have questions about simulation, you're running into trouble, feel free to approach me, shoot me an email. I'm happy to help out. We're all peers and we help each other. Okay. And thank you. So I'm trying to find the chat box.
It doesn't look like there's any questions in the chat right now, but did anyone have any questions? I think I heard something, but I wasn't sure. Anyone had a question?
And again, I realized it's a lot of material we're trying to squeeze in this lectures. The lectures will be available to you. And I've also shared with Radiating Hope all the major task groups and papers I mentioned in this lecture, and they should be, hopefully they can be made available to you as well as resources. And feel free always to reach out to me as well with questions.
Oh, I think someone asked a question in the chat now. It says, can you please elaborate a bit on the use of gating and motion management in breast cancer?
Oh yeah, I did not cover breast because this was specific on IMRT, but I highly recommend it. I'm trying to find a slide. So the issue with breast is lung, of course, and heart dose, especially with the long survival rates. Where is my slide? Have it in the beginning. Yeah. So what we do for breast now in UC Davis is if the patient can tolerate it, we actually treat our breasts prone, like it's shown here, because it allows the breast tissue to fall away from the chest wall and from the heart. And it's especially good for large-breasted women because you don't get the erythema in the intramammary fold, in this area where supine, there is a skin fold there that often gets a little bit irritated. The advantage of this position is, of course, that it is a respiratory motion management, because your chest wall here doesn't move because your body weight on it, and all your breathing motion goes into the back where it doesn't interfere with treatment. We at UC Davis, for patients that cannot be treated prone or that need a superclav or IM node treatment, which we cannot do with the prone approach, we do a very simple breath hold technique. The advantage is that most breast cancer patients have very good lung functions. They tend to be younger and healthier than some of our other patients. So they can tend to be able to deal with breath hold very easily. And we started out simply by verbally giving them the breath hold commands and switching on and off our Linux. And then eventually we implemented the external monitoring. So that is clearly, that's the way I would recommend going. Put the patients that you only need to do 2 fields or a boost on a prone belly board, so on a prone breast board, so you don't have to think about motion. And those who need a superclav and IM, put them supine and use breath hold, because these patients can do that very well. And breath hold tends to be a little bit faster than gating. If you have gating functionality, by all means, go ahead and use it. We tend to gate actually for breast on the inhale, because if you gate on the inhale, you have the most separation between the chest wall and the heart. So that is actually the one exception to the usual gating rule. Usually we say gate on the exhale because it's the most reproducible. The exception is breast. There you gate on the inhale because you increase the separation between chest wall and heart. Yeah, I hope that answers the question. Gating breast cancer, okay.